Hello, hello, everybody. How you doing, Miss Liz?
Good. How are you, Chris?
I'm good. Today's an awesome day. How you feeling about life?
Good. Happy to be back. I know I was out. I feel like I've been out for a little while, so I'm excited. I mean, I know we've been back with some of our panel talks, but I'm excited to be back with just you.
I know. It's weird because I'm so used to doing it with you. So anytime I have to do it solo, like I'll ask a question or I'll say something, and then I'm like pausing and I'm like, oh yeah, Liz isn't here. Or the other like really hard thing to do is to try to both read the live questions and the submitted questions when you're solo. So you had
Yeah,
it down like a science because I finally was just like, okay, I'm gonna do all live ones and we'll get to
we'll get
the
to the other ones
questions.
later. Yeah. So I know
Yeah.
we probably have a ton to get through today, and I am excited for us to hop in. How are you, and how's life, Chris?
I am really good. I'm excited to be here. I always really enjoy this. I think, I get a lot of feedback on social media and stuff of just how many people are like, hey, look, like we're on a waiting list somewhere. We haven't been able to talk to anybody. Like the answers to your questions are just some general things that have helped us before we can get in with therapists. And I always like hearing that people are both using this as support, but also encouraged to find like, evidence-based, like specific help for the disorder. Cause I always tell people like, this is a really tough disorder to fight on your own. So I'm always super excited when people use that as motivation and they hear, kind of the answers that we have in our stories and really propel into treatment because of that.
100%. I was just talking a little bit ago about waiting lists and what kind of happens, and I think like this is so fun because it's an opportunity for us to hopefully give some education and support. And the thing I always want to push is I'd rather you wait for the right care than be getting into someone quickly who may not be able to offer the best treatment and evidence-based care for you. But I also think this is an opportunity for people to get a lot of questions answered and for support that a lot of people otherwise don't have. So I just love doing it with you and excited to see everybody here. So let's hop in. So if you have any questions, please make sure you post them live. Hi to everyone. Love seeing people from the US, from Dublin, and all over. And we will certainly get to questions that they're here. And a couple things. So just a reminder, this is not intended to replace therapy. IOCDF and or our live streams are not crisis hotlines, and we don't serve a crisis line. So if you're feeling unsafe or suicidal, we want you to keep yourself safe by calling 911, going to your local emergency room, or calling the suicide prevention line. Of course, that's different if you're not in the US, and so make sure you follow your local emergency service options. This is also not intended to replace therapy. So Chris and I do our best to address questions that come up and to give feedback and education and hopefully support that's helpful, but we are not your clinicians, and we really want to encourage everybody to make sure that you are seeking your own individual therapy, because again, while we can give some general advice and feedback, individualized treatment is really the best option, and all treatment should be tailored to meet your specific needs. But let's hop in without further ado. So let's just go ahead and start with a couple questions that were posted, and then we'll go to other ones. So yes, you can absolutely post questions about doubts you have in therapy, and we will do our best to answer them. There was a question about an intrusive thought, Chris, where Badhan asked if he found that he had a terribly disgusting intrusive visualization that popped into his mind. The thoughts and images gave intense, I think they were really intense, a lot of anxiety, and he wants to get rid of them. So let's talk a little bit about how we address it, but also how to address the shame that comes with why we may have wanted to read, why even I ever wanted to read something that then became disturbing or difficult. And I actually was just talking about this with someone this morning, is kind of like OCD can be here, and then shame can often follow as well for all sorts of different reasons. So if you don't mind, like touch a little bit about both.
Yeah, so I'll start with shame, and this is a shameless plug, obviously, to the IOCDF conferences. I'm actually doing a talk on shame and OCD at the virtual conference, so please, please, please support the IOCDF conferences. They are life-changing. The thing that happens is we do things that are ego dystonic, meaning that we do things when we are struggling with OCD that are kind of against our values. And part of OCD, unfortunately, is this constant need to like search things out to get answers. And so one of the things that I hear from a lot of different clients, and I think I experienced myself, is when we are struggling with OCD, we may do things, we may do compulsions, we may check things and stuff that we're not proud of. And later, when we have much more of a clear state of mind, we look back and it's like, in Badhan's case, like, why did I look up this erotic story I saw online? Why was I looking at pictures of somebody of the same sex and seeing if my growing, had a, sensation? Like, we find ourselves doing those kind of checking and searching and curiosity compulsions because we just want relief. We want our brains to shut up, to leave us alone, the anxiety to go away. And so we're willing to do anything, especially when we're undiagnosed and not receiving treatment. So then what happens is we have all this shame. And remember, shame is different than guilt. Guilt is you feeling bad for something you did. Shame is basically feeling bad for who you are. And so that's why it's so important. There's a million things we could talk about on this topic, but what's so important is to separate ourselves from the disorder, because if you're owning that shame, it's going to make you feel like a terrible person. And then we see clients struggling with depression, isolating from other people, and punishing themselves as a compulsion. And so trying to figure out, why did I look at it, and putting yourself down for it and using really hateful words isn't going to help. And that's where self-compassion can come in. To answer the first part of your question, that is the disorder. I think a lot of people get so frustrated that they have intrusive thoughts. And I remind people, you have to have intrusive thoughts to have OCD. That's the O in OCD. And so somebody who breaks their leg doesn't wake up and ask themselves why they can't walk. They get it. It's how they deal with that through, PT and other things. Same for us. We can't stop the fact that we have intrusive thoughts pop up in our head. It's what we choose to do with it. And if we make the mistake of analyzing it, trying to search the origin, asking ourselves why, replaying it in our heads, punishing ourselves, that actually just makes the feelings more intense and keeps the thought around. And so what we're really trying to do in this place is response prevention. So it's allowing the thought to be there. It's already there. Allow it to play out to completion. Allow your brain to kind of just let that thought pass, and then really not allowing yourself to go in there and do anything with it. And that's what a mental compulsion is. It's really, or a mental exposure is to really refrain from doing those mental compulsions. I'm gonna let Liz take over because I talked a lot, because there's so much to answer this question.
No, you've got it. I love it. I think that's totally right. So let's just keep going with questions. Sorry, there's a lot. So I'm trying to I see how you're like, how did you juggle all this on your own? It's so much.
Hard, right?
So why don't we just hop in? So one of the questions, the first question that was pre-submitted, we're going to go to pre-submitted for a little bit, is we talk a lot about ERP being the gold standard evidence-based treatment for OCD. Is there any information available on other approaches like IBT, IFS, schema-based therapy, etc.? You want to take it, Chris?
Yeah, you know what? Actually, there's a Facebook group that a lot of OCD specialists are part of, and they've been talking a lot about like ICBT and other types of treatments. What I feel, and I actually, Liz, wish we could do maybe next year at the conference, just like a big discussion, because in my opinion, I think what starts to happen is if ERP doesn't work for someone, people start to kind of attack ERP itself. And I think I get very defensive because ERP was so effective in my life, and then I see it help so many clients. What I will say is that people are using kind of ACT, using ACT as in conjunction with ERP. And I do think that for some people, that kind of presentation of ERP makes a lot more sense. So instead of pounding this idea, like you have to touch that door handle, your anxiety is an 8, you have to watch it go down to a 1. Sometimes that doesn't really click with people. But presenting it in the topic of like, how is not opening door handles impacting you? What are some things that would open up for you?
Right.
Okay, you want to go out, you want to travel, you want to be able to open doors, you want to be able to go into malls, go into stores, buy your mom a gift. Okay, do you see how OCD is negatively preventing that? The ERP isn't this like evil, like torture you kind of treatment that I think some clinicians present it as. Instead, it's this amazing opportunity to overcome this fear that isn't even real in the first place and really push through that anxiety and that uncertainty so you can start becoming autonomous, opening doors, which means you can get your mom that gift that you want to get her at the mall. You can go out with friends and go into restaurants and things like that. So what I've been hearing from some people is like, if they don't feel ERP works, like what about, these other treatments? What I always caution is the reason I personally like the term and really support evidence-based as a treatment modality is because we have so many people in this field. So many people in this community with OCD that have received treatment that wasn't evidence-based, EMDR for OCD, hypnotism for OCD, psychotherapy for OCD, and they have exactly no results. And then they feel burnt out from therapy, not recognizing that there's a treatment specified for it. So I do think that these other kind of presentations that you mentioned here, they are being utilized by some clinicians. And I think there still needs to be more research and more evidence, but I do think it's a bigger topic we can have for people that aren't finding ERP's presentation clicking with them. Is there other things that we can do? But I always think, and I'd love to hear your opinion, Liz. I don't understand how you could ever do OCD treatment without ERP, because let's say you're having intrusive thoughts about harming your nephew. Eventually, you're going to want to spend time with your nephew and push through that, and that is so important.
Yeah, I'm with Chris. It kind of like fires me up, and I usually have to like take a deep breath and remember that like treatment looks different for everyone, right? And here's what I will say. I think that we sometimes get black and white. We think that like if and right, I have had ERP from multiple providers that it worked great from some and not great from others because of my relationship with them or the way they did ERP. And so it's important to know that just because someone says they did ERP and it doesn't work for you, or it didn't help move the needle for you, doesn't mean ERP in general doesn't work. It may be that provider's application of ERP or implementation of it, and or maybe just your rapport with them didn't allow it, right? If you don't have a good rapport with someone, you're not going to want to do ERP with them. And there's going to be a lot of hesitation and resistance, and we all do it differently. So I really think ERP works. I have never found ERP to not work for OCD to some degree, right? So even patients who end up getting something like DBS, deep brain stimulation, they still return to ERP after, right? Patients who are emotionally really dysregulated and might need DBT first, DBT is still really important, but the DBT isn't to address OCD, it's to address the distress tolerance and emotion regulation so that they then can be able to engage in ERP. And so I think it's really important for us to say, we know ERP is the gold standard and is the most effective treatment for OCD, but it doesn't mean that other modalities don't need to be used first or in conjunction or after. And oftentimes that may or may not be for OCD. One of the things we talked about, I think this was a couple weeks ago, Chris, that I've been pushing a lot too, is that it is very rare that patients have only a diagnosis of OCD. Most patients have diagnosis of OCD, anxiety, generalized anxiety disorder, maybe a related disorder. They might have a personality disorder. They might have depression. They might have a substance use disorder, right? And so ERP is not the gold standard for a lot of those other conditions. And so we absolutely have to say, okay, if you live with OCD and PTSD, we're not doing just ERP. We're doing ERP plus cognitive processing therapy or plus prolonged exposure, right? Which is the effective evidence-based treatments for PTSD. And so that's what's really important, is for us to also, I think a lot of times, one of the things we talked about last week through an IOCDF meeting was that, so many times people think, oh, well, I experienced something that was difficult and we'll label it as PTSD, or I'm struggling with this, it's my OCD. And it's really important for us as clinicians to sit back and say, let's talk about what defines something as being OCD versus not, or whether it defines and meets criteria for being PTSD versus a tough situation or a challenging situation. Because again, we need to understand exactly all of our clinical presentation to be able to appropriately treat it. And so I do see a lot of times that we're labeling everything as OCD, and maybe ERP isn't working, but maybe it's not working because these things maybe actually aren't OCD. They're other things, and that's okay, but we need to use the evidence-based interventions for those. ACT and ERP do make more sense for a lot of people, but what I want to be clear is that the research has shown us to date that ACT can be an effective intervention with ERP. So ACT and ERP are shown to be as effective as ERP. ACT alone is not, right? And so that's where it's really important. Most ERP providers are using ACT. We're using functional analytic psychotherapy approaches. Like, that's a part of what we do and a part of how we engage in treatment. It's not just this like, oh, here's ERP in a nutshell, this is all we do, we don't bring in other modalities. Like, that would make us not a human and not empathetic and not meeting our patients where we are, which is our ethical obligation. Okay, so let's hop back to questions here because we're getting a lot of them now, which of course means we only got through one on our pre-submitted. So with that list, we'll just keep growing. Okay, when I pay for 1105, when I pay for something and get the change, I keep on checking in my mind if it's right, even though I know the answer and it's frustrating. Is ERP to check on purpose?
Yeah. So based on the question, Costas, I mean, what we always want to ask ourselves is like, what is OCD asking us to do in that moment that we don't really feel like doing? So if in this case, checking in your mind if you had the right change, for instance. Sometimes what might work better for this one is to just live in the doubt. So kind of either not check or not. I'm just trying to see. Oh, checking in your mind. Okay, so I thought they were like actually
I think
looking
the
physically
checking
at
is
the
actually
coin.
the ritual. And
Okay,
so
I
he's
see.
asking,
Yeah,
is the checking the exposure? And I would push that the checking is probably the ritual, and the exposure would be to
yeah.
not check and to lean into the fact that, like, like, I don't know for sure if I got the right amount.
Yeah, exactly. So I just was reading the question. I didn't know if he meant he was like physically checking the coin. So now I see what you're saying is like checking. Sometimes when your brain is automatically checking like that, Costas, the ritual sometimes can be you want to just check and get it over with and get the answer. And so it is going to be to refrain from checking. What I hear underlying the question, and this is what I hear from a lot of people, is when things feel automatic. So if they feel like, we've had somebody ask this question on the chat before. Is like, when they walk in a room, they're kind of automatically like counting how many people are in a room, or I have clients that will walk into a room and start immediately counting how many lights are in the room or things like that. And they get very frustrated. They get very, very frustrated that their brain kind of almost starts to automatically shift to that. And what I would say is that like intense frustration and that agitation and all that is just exacerbating the OCD. The OCD needs you to be impacted. So in this case, if like, you're paying for something and you get change, and then your mind is kind of wanting to count how much change you have, obviously giving into that would be a compulsion. But the other part here that's not working for you is getting so frustrated. Yes, having OCD sucks. It's frustrating. It's agitating. We all don't like it. But if we always have this like overwhelming negative emotional response and we kind of buy into that and we're frustrated and we're angry, why do I even have OCD? That's going to bring on the OCD even stronger. So it's really just not letting OCD get under your skin, which is a science. You get good at that over time. But when I started getting intrusive thoughts about harming people in public, I no longer got frustrated. I was just kind of like, oh yeah, not surprised. Figured OCD would do that. And by just not really having an overwhelming frustrated response, the brain got bored with OCD and started to fade.
Totally. Yeah. So it really cost us. And again, for everyone listening, the goal of ERP is, can we lean into uncertainty and not try to solve, not try to be sure, right? Your OCD pulls you into certainty. We want to pull you out of it, because the more you try to be certain, the more stuck you get. Chris used a comment a couple weeks ago that I've been using all the time, which is that compulsions make us confused and solving gets us stuck, right? So we want to remember both of those. So let's keep going. There's so many, and I have a goal, Chris, that we're going to get through all these somehow.
Okay,
So
let's go.
we'll see. Next one. I get separation anxiety whenever I leave my partner for a week or so. I get really worried something bad's going to happen to him. I think it's because it's out of my control, and I get worried that something will happen to him and he could be ill or die and I won't be there. Tips on how to deal with it. I think I have a specific fear of them dying, and specifically me not being there for them.
Yeah, in this one, what's basically going on is the OCD, the anxiety, et cetera, wants to have you have an extra layer of control that none of us could ever have. It's wanting you to figure out some way that you could prevent anything bad from happening to your partner. And so there's a false belief that you're getting that if by chance they're in your eye line, you could somehow prevent anything bad from happening. And the OCD and anxiety is basically taking away their autonomy. Is this kind of idea that, hey, they're not strong enough to handle anything alone, but if I'm there with them, I can prevent something bad from happening. And I think one of the hardest kind of mental acceptances that we have to get with OCD, with anxiety, et cetera, is that we're not in control of everything. And sometimes bad things do happen. And obviously, none of us are saying we want that to happen. But if I'm in a relationship and my partner travels, yes, of course, it might be natural to have some worry. But what the OCD does is has you ruminate, because in real life, you can't do anything about it. There's nothing you could do if your partner does have something bad happen. So OCD says, well, that's not good enough. So at least you need to sit here and just ruminate and come up with solution. And that's where people come up with mental compulsion. So what you're not going to want to hear, but the way you really deal with this is you kind of almost own your limited ability to protect your partner and to just say, look, if they're not in my presence, something may or may not happen. And I don't have control of that. But me sitting at home, just ruminating, being miserable isn't keeping them 1% safer. So I'm at least going to engage in the things that matter to me in life and really trust that my partner is going to make smart choices. And ultimately, if something was to happen, I'd have to deal with it then, but there's nothing I can do about it now.
Absolutely. The big piece too is, how can we really focus on leaning into living life instead of getting stuck, right? And so what I also hear is this like greater good goal of being able to travel and being able to do things away from your significant other without being preoccupied with worry. And a lot of that is going to come with just leaning in and allowing those experiences to be there. Should ERP be very hard and painful to do?
I'm glad somebody asked this question because once again, going back on my defensive ERP, I think I think if you're seeing a clinician that maybe doesn't really know ERP, doesn't utilize it a lot, it may feel like fear factor. It may feel painful and hard to do because I have heard stories from clients that they worked with a therapist that wasn't really an OCD specialist. And the therapist didn't really do a hierarchy. They didn't work up the ladder. They kind of just threw them in to like great fears. The person didn't really have the mental tools, etc. What I think about as ERP is, let's say somebody has a hit and run OCD, so they have thoughts about hitting somebody with their car. The bottom line, especially at least here in California, is you can't really survive without a car. And so what I would start with the client is I'd ask them, like, what has not been being able to drive consistently negatively impacted your life? Why I missed my nephew's baptism. I didn't go to my daughter's quinceañera. Like, I don't work anymore at the office. I work from home. I don't go to my friends' houses. People have to pick me up and I feel really guilty. Okay. So now it's like, okay, see how all these ways that not driving has impacted you.
Right.
Do you see how driving is going to open up these amazing things in your life? And so I don't want to it's not fear factor. I don't want to shock you. So let's start really slow. Let's just start sitting in your car and having a conversation. Let's just have our session in the car instead of doing it in the office. Let's go down to the parking lot. What about driving me around the parking lot? And starting to work up to that. So if you're doing it at a comfortable pace and somebody really sees value in it, is it going to be easy? No. Is it going to be difficult? Sure, because we're facing things we fear, but it shouldn't be like painful and the worst thing you go through. It shouldn't be traumatizing, and it shouldn't be, like I said, you're not supposed to just like shock yourself into doing something. It's really, if you're working with a proper therapist, it's a really kind of strategized way of doing it so that you can handle it and learn from the treatment.
Absolutely. And the thing is that at the end of the day, should ERP be hard? Yeah, right. We're asking you to face things that you haven't faced in a long time, and we're asking you to push through and do something different, right? So it should be challenging. Like if you're not feeling anxious, we're probably not doing it right. But it shouldn't be like Chris said, fear factor, and it also shouldn't be something you dread. It should be something that you see as an opportunity to, I kind of think of it like a personal trainer, right? I'm probably
Mhm.
not going to be excited at the thought of like when I have to drive to the gym and go to the personal trainer, but afterwards I should feel really good and I should feel really excited and hopeful about next steps. It should be very similar with OCD. I'm going to answer the next two questions in one.
Of
There
course.
was a question about, are there any scientifically proven naturopathic treatments for OCD? And how do you feel about hyperbaric oxygen chambers or ozone therapy? So neither of these are evidence-based interventions, and I haven't heard any reason for us to believe that those would be the treatments for OCD. With that being said, there are definitely things that people can do, eating healthy, exercising, taking care of yourself, that can have a positive impact on your mental health in general, on stress in general, which we know will also impact OCD, right? If we're not eating well, we're not sleeping well, if we are not taking care of ourselves, that will probably increase our vulnerabilities, our stress, which can increase OCD. But there's not any science or research for us to or that we have that we could say those are good treatments or that's a way that you would treat and address the OCD in and of itself. But there are ways that you could hopefully reduce some of these other symptoms that might contribute.
Can I add a
Next,
sentence to that? Real
yes.
quick sentence. And I promise you, Jeff's not paying me, but the one more shout out for the virtual conference in November. I'm actually doing a talk on that. So my mom's a registered dietitian. I'm linking up with Tommy, who is a trainer and really hard in the physical fitness world. And then I'm working with a certified like yoga and mental mindfulness instructor. And what we're doing a talk on is that all the things that Liz just said do not cure OCD, do not treat OCD, do not, that is not the lead treatment for OCD, but it is absolutely important that you are also taking care of yourself in different ways because it can help reduce anxiety, which makes you have more, distress tolerance to face the OCD.
Totally. Next question is, I have sleep anxiety due to chronic insomnia. Before bedtime, my nervous system is not relaxed and adrenaline flows easily. If this happens, the body is awake for many hours despite fatigue. Further, my OCD will wake me up at night. Is there a way to calm the body down and fall asleep without medication?
Yeah, so I dealt with this really bad, and I believe what happens for a lot of people with OCD is two things: is when you're laying in bed, you are not distracted, you're not moving around the day, you're not doing activities, and so you're literally just laying there with your intrusive thoughts. And what happens is when you're having intrusive thoughts, especially if you're giving into them, your fight or flight system kicks in. Some of those stress hormones kind of pump you up for that fight or flight, and that system is what wakes you up in the morning. So then you're struggling to fall asleep when your body thinks you want to stay awake to fight something off. The other thing that happens is then people get very hesitant and have anticipatory anxiety about sleeping. They get really anxious about having to fall asleep, and they get really, really worked up. And so then they have dread going to bed. Typically, what clients will do is they'll go on their phone or play video games until like the wee hours of the night, until finally at 4 a.m. they just pass out from exhaustion. And so what I've worked on with clients is, a, you know, I love narratives or worry scripts. And so having someone do that, not right before bed, but in the evening, so that they're really kind of addressing those intrusive thoughts and they're practicing that acceptance and not giving into the mental compulsions. And then the second thing is really working with the client that if your OCD is around falling asleep, and so you just lay in bed and you're aware that you're not asleep and you're anxious about it, is to really not try to fall asleep. Instead, lay into bed. Make sure you do all the sleep health hygiene stuff. I definitely work with that clients to understand proper sleep hygiene. But once we've gone through that, practice just lying in bed with your eyes closed and resting. I usually tell a client maybe use a sound machine or like Beethoven, not some song with words, and just practicing laying there and just relaxing and resting. And when your brain is like, I'm not asleep, it's like, you're right, I'm not trying to sleep in this moment. I'm really just trying to relax and rest. Over time, I even do it in my office. I find that clients actually fall asleep because they don't have the pressure and they're not kind of trying to psych themselves into sleep, which doesn't work.
I want to just emphasize one of the things Chris said that some of you are probably cringing in the background on, which is one of the things you heard him say is, we actually want you to face your fears before you sleep, right? So a lot of times I think we have this belief that like, well, I can't do exposures before bed, or like I can't try to address it because then I'm going to be triggered. But what we actually are finding and you're talking about is that the suppression and avoidance just keeps it popping up. And so if we actually do some of the worry scripts and lean into it and try to not avoid it, it will allow you to have more freedom at night because you've addressed it. That feels opposite of what probably you think would make sense, right? Well, why would I purposely trigger myself before bed? It's like, because otherwise the trigger just follows you, right? And it keeps lasting. The second piece I want to throw in too is I have seen a lot lately where OCD is attaching to sleep. This fear of like, am I getting the right amount of sleep? Am I getting the perfect hours? If I don't, I can't function. There will be all these. And so there's so much emphasis, time, energy, you name it, on sleep. What we know is that that just increases the likelihood that we're not going to sleep, right? And so we really want to be able to lean into that.
Exactly.
All right, next question. How do you feel about an interventionist working with an OCD sufferer's family using standard techniques like they would for an addict to get the loved one to go to treatment? For example, doing an intervention and then cutting off accommodations completely and abruptly after the intervention. Would you say it can be helpful, or is too different from addiction to handle it that way? I'm happy to answer this because I've seen this happen. So I have seen where there has been an interventionist who may help be the person to kind of mitigate going to treatment. And it can be useful at times if it's done in a healthy way and the person is really there to be a support person and a tool. What I would say is that in general, we rarely recommend that OCD accommodations are just abruptly cut off. We want that to be done together with a provider so that the individual can actually feel supported and feel like it's a process that they're a part of versus something that's just happening to them. With that being said, sometimes patients, adult patients that live at home, may struggle with the slower process of accommodations being removed. And so I would just say, I want to make sure that you're working with an OCD specialist versus an interventionalist who usually is not an OCD specialist, to decide what makes the most sense for your family. This is where it's really hard for Chris or I to say, here's what you should do, here's what you shouldn't do, because it just depends. Like, we don't know your situation, we don't know the details of it, but we really want to be working with an OCD clinician to work together and to make sure that individual is a part of the process and not just it's happening to them.
Well said. I don't really have anything to add because you said it perfectly. And I would say that always make sure OCD specialists involved because an interventionist isn't going to know the
Yeah.
disorder at all.
Yeah. There's quite a few questions on medication, so we're going to save those because I know we're planning to have a psychiatrist on soon. So the next question, my adult son who's 38 has made improvements on his compulsions on his own. He had 2 psychiatric hospitalizations and says he didn't do ERP there. He's virtually attending his first ERP session with no CD. I've been living with him. I have improved on my reassurance and will stop today altogether. I'd like to have my own life back living with my husband, which is his father overseas where we have retired. My son says I can't leave. I think he should learn through therapy to live as an adult so I can have my own life. I can't live with him forever, and I think he's lonely. How do I handle this?
Yeah, no, I mean, I think if it is the loneliness factor, I get it, right? And I'm sure Liz, you get it too. Is like when you're in the just like the throes of OCD. I mean, I remember waking up one day and being like, dang, I don't have friends, I don't date, I don't have anyone. And so your family does become your only friend. What I would want to say is if you feel like your son is in a stable enough place that he's not going to do something drastic if you leave, what happens is when somebody has reliance on you, right? Like as a parent, if you're living with your son and he has you, he may not feel that urge to kind of go out on his own. And what I would really encourage him to work on with his therapist is like, hey, part of my treatment is I'm isolated, don't have friends and don't have people. And so when I'm working with a client and they don't have any friends, they're not dating, et cetera, I incorporate that as part of their therapy. Sure, it's not ERP, but I'm like, let's get you signed up for a cooking class. You like dancing? Let's see if there's dancing classes. Because once people have interests and passions and friends, that becomes way more attractive than the OCD. And so what it sounds like is your son is just absolutely terrified to be alone and he wants you to kind of be there. And I hear you. You're tired. You want to move on. You want to retire. You want to spend time with your husband. And I think that, you know, if he's working with an OCD therapist, what you can do is just maybe work with the therapist to find out a timeline. You know, is there a realistic timeline where you could still leave pretty shortly and not stick around forever and start making those plans? And that gives him time to transition into making friends and a support system. He could always start with a support group in his area so he could meet like-minded people. I just don't think it would be a good idea for you to just camp out and stay around for X amount of time and not be living your life, because I don't know if that's going to really encourage him to ever kind of go out on his own.
Yeah, and I think the biggest thing I just want to kind of emphasize too, because I think Chris and I have probably, I think you do too as a parent, right? But like, how can we discuss these things? How can we implement boundaries in an empathetic way, right? So how can we balance this need for empathy with a need of boundary setting? Next question is, and I'll take this one, but what is it called when a person is an actual trigger? My daughter can't be near me as I'm a trigger. It began with her brother, then her dad, and now me, and she lives with my stepdaughter now as a result. So I don't know that it's called anything except just that, but oftentimes individuals may become either physically contaminated or emotionally contaminated, and OCD will attach to that. And so this is something though that we want you to work through in therapy. We do not want somebody who's a trigger to just start moving, right? So this is kind of the thought when people say, Liz, my car's contaminated, I'm going to get a new car. And I'm like, great, so we can contaminate the new car? And they're like, well, no, so it can stay safe. And I'm like, that's not going to happen, right? Like, that's not how OCD works. So most likely, the stepdaughter will become contaminated, and contamination shifts and moves. So removing that person, it may give temporary relief, but it isn't going to actually address the OCD. We still want to address it and slowly do ERP. Great news, ERP still works incredibly, even if individuals become contaminated. Next question is, hi, Liz and Chris. Thanks for the great work you do. And Chris, we've got really great, sweet comments about you and your videos and how impactful they've been to people. So totally agree with all of that. Chris is a rock star.
Thank you so much.
Do we have to do the specific ERP daily? I used to sneakily think of escaping from having to do ERP after a point, and I don't think so anymore. But practically, do we have to keep practicing specific ERP? I understand the ERP is so different for each person and every situation.
Yeah, what I would say is the key when I notice there's a shift in a client is when we start doing proactive exposure. So for instance, if somebody puts on a shirt and they have the urge to put on the shirt over and over and over until it makes them feel just right, and we're working on no longer doing that, they're putting on the shirt once and moving on, they're only going to put on a shirt once a day. It's going to take them forever to get over that fear, right? If instead the person is going out of their way to like put on a shirt 15 times a day to practice it, they're going to be kicking OCD's butt, and they're doing it on their terms. There does get to a point where I'm working with a client and we've pretty much done everything on their hierarchy, and they're no longer really struggling with any specific exposures. And they're like, well, it doesn't bother me to open door handles or drive anymore. Do I still have to do that? And one thing that Liz and I have been screaming from the mountaintops is that's because what we do now is we stop kind of like doing ERPs and we make ERP a lifestyle. So an example for that is if I have a client with hit and run and they fear driving near schools and they have two ways to get to work, go the route that you go by a school. For me, I didn't like mayonnaise because I didn't like stickiness, because I was afraid it was going to get everywhere and just caused such a gross feeling. So I made sure to get mayonnaise on food. It's like I just kept that as part of my lifestyle. There did get to a point with preference. I kind of hate mayonnaise, so I stopped putting it on because it was just, I didn't want to do the exposure anymore because I hate the taste of it. But it didn't bother me anymore. And if there was mayonnaise on something, it didn't bother me. So there is kind of this transition from like doing ERP to making ERP a lifestyle. And once you get to that point, you don't really feel like you're doing ERP anymore. It just feels like a lifestyle. So you're always kind of finding new ways to live in your values. And most of the time, the OCD will pop up and try to stop that. So I don't think there's ever a point that you just stop ERP. But I don't think there's a point that you need to like have a list and check mark each day. I don't have like a list anymore and do that, but I'm making sure that my life is filled with things that I know would drive it crazy at one point. I had a lot of OCD around fast food places. I still go and get fast food now, and it always kind of keeps me in check. And last thing I'll say, and I wonder if Liz feels this way, as a therapist, I'm doing exposures all day long. I'm touching things, I'm talking about things, I'm watching things. So I do believe that's part of why my recovery has been so strong, is because as a therapist, I'm doing ERP every single day. And I do believe that's what helps me. So there's never really a day you stop doing it, but there is a day where it starts to feel like a lifestyle and it becomes part of your recovery.
Totally. And the thing I'll say is that ERP doesn't have to feel like ERP. It can feel like living life, right?
Mhm.
So like I don't do standard ERP anymore. I used to like have to set aside ERP hours, and if I am struggling, I will set ERP requirements and accountability ways to keep myself accountable because I need to. But for me right now, ERP is living life. It's being with my daughter, it's coming to work, it's, doing things that I may not want to do sometimes, but it's living life. It doesn't have to be this like standard I sit down and do 2 hours a day. I saw a frightening commercial about an upcoming show while I was on the phone with a dear friend. The trigger made me panic. I made a correlation and felt awful and numb for the past couple days. How do I deal with this feeling?
Yeah, I mean, one thing that I'm guessing that you're doing, it sounds like in the question, is that commercial has now been kind of like bookmarked as this like bad thing, and there's a lot of avoidance. And remember, like when we were kids and we kind of avoided the closet because there might be a monster in it, pretty soon our brains created a whole story. And then Disney created, or Pixar created a movie that like solidified our fears. So that probably wasn't good. But basically, like, we built a story of these horrible, like kid eating monsters because we never faced it. And then you get to a point one day in the middle of the night, you finally just open up that closet and realize all it is your clothes and your shoes. And it's not very exciting anymore. And it doesn't spook you out. So in this case, what I would say is that if you feel that you can do it with response prevention, remember the RP and not doing compulsions is important. They put all commercials on YouTube now and online. So I'd find that commercial and watch it again. And this time you're going to be doing it proactively, and you're going to deliberately choose to watch it. And you're going to get a flood of thoughts and feelings and emotion. And then your goal is to really not respond with a compulsion. So I don't know your specific compulsions, but they might be looking away or rumination or things like that. If that is too triggering for you and you can't do it, and you're finding yourself doing too much compulsions, it might be writing out a trigger word from that commercial. So if the commercial was about, I don't know what a frightening commercial would be. All of them are frightening and boring, and I hate commercials, but I'm thinking like if it was like a monster, maybe writing the word like monster, or, playing the commercial, but only hearing the audio. But the idea behind it is not to like torture yourself, but I always try to tell my clients, like, what we're doing as an exposure is a little thing, but what I'm trying to teach you is a bigger concept. And so the bigger concept I'm trying to teach you is your whole life, there's going to be commercials, movies, songs, things people say that are triggering. And if we try to control and run from it, we'll never get to a point where we can live freely. So the idea is to push yourself into some of this stuff so that when it does come up organically, you don't have such a visceral reaction like you do now.
That's right, 100%. Next question is, psychologist Fred Penzel says that it's good to agree with the thoughts as a way of disregarding. Is this true or an effective way of thinking?
Do you want to take that first, or do you want me to take it
I'm
first?
happy to. I think it depends. I think that oftentimes, I think what Brett is saying is that it's the choice not to respond. So it's kind of to be like, oh, maybe, like, who knows, right? Or something like that, versus trying to engage with it. The more we try to solve and understand and figure it out, the more stuck we get. And so I totally agree with the thought process of like, can we just kind of let the thought be and like, maybe, maybe not, or who knows, and not try to solve it, right? Because that's really where the key is.
The only thing I would add is I always remind.
Sorry, I'm going to say really quick.
Yeah, of course.
Don't believe that we have to agree with it. Sometimes these thoughts are like, what if I'm a pedophile? I don't have to agree that like, yes, I'm a pedophile. So Chris, myself, and Callie couple, I think, are doing a talk at the online conference where we're going to talk about like, we don't have to accept our worst case fears as being reality. Like that isn't needed. But what we can't do is fight with them all the time, right? Fighting with our thoughts gets us more stuck.
Yeah, and a lot of clients get really stuck on the word of agree. And what I try to explain to them, if they have seen that in the literature, is no clinician is asking you to agree that you're a pedophile or agree that you're going to kill your mom. What it basically is OCD is presenting you with a negative message, and it wants you to get into a fight, into a conflict. And just like sometimes in real life, you kind of agree with your boss, or you sort of agree with your parent just because you don't want to fight. It's really that kind of concept. Agreement doesn't mean agree doesn't mean that you accept or you like or you really think it's going to happen. So if OCD is like, hey, Chris, you're going to hit somebody with your car, it's like, thanks, OCD. Super interesting. Thank you for sharing that. You could be right. Great. And then moving on. So it's not like I am hitting somebody with my car. I'm a bad person. I think that's where people really get stuck.
Totally. Okay. Do you want to hop to live questions, Chris? And then we'll
no, absolutely. Because I know we got a lot of medication questions. So we just got a little inside scoop from Skyla that for our Ask the Experts on Wednesday, June 1st, we are going to be asking medication questions. So we have a bunch of questions on medication. Also, if you're watching this live and you have questions about medication, please come back on the 1st.
And we're working to take any ones that are posted here and put them in. This is when if you hear my mouse clicking, that's what we're doing. Is Skyla and I are kind of updating all these questions to make sure we have them.
Perfect. So I'll ask you this one, Liz. It's at 12:34 your time, Skyla from ANSA. How can we realistically measure our progress with treatment?
It's a great question. There's two ways. So the thing I always want to look at is we do want you to consider or have your provider consider engaging in measurement collection, which often is used through the Y-Box. So the Y-Box is the Yale-Brown Obsessive Compulsive Scale. It's a standardized measure that we use to really assess OCD severity. And what we should find is that with treatment, the severity level should go down. So you should see that with appropriate treatment, your OCD becomes less severe. 16 is the clinical cutoff, which means that often under 16, someone might not even meet diagnostic criteria. The second and more important marker is, are you getting back to life? Are those ways that OCD was interfering with functioning, with life, with freedom, with engagement? Are you able to start doing that again? Are you able to start being with friends, being with family, and being more present, right? And that is the bigger, more important marker, because that's the freedom you're really fighting for.
Well said. Another question that we had at 12:20 was from Chaitanya. Every time I see these beautiful names, I'm like, really, Mom, Chris? That's as creative as we got. Okay. It says, sometimes there are obsessive thoughts which are on genuine safety issues. Here, I do find it difficult to tag them as an obsession. The very genuineness in that issue makes me kind of want to bog down. And I think that's good, because we had another question about like COVID and stuff. So Liz, like how, when it's around a real issue?
Yeah, it's a great question. And it's important to remember that OCD usually attacks or latches onto something that's rooted in reality somewhere, right? Chris talks about the fear of when they're like termite fumigation or maybe chemicals, right? And like no one wants to be like, there is some reality of exposure being dangerous, right? That like there is a little bit rooted there. But OCD takes it to a whole nother degree, right? Where we're avoiding the block, we're avoiding the entire area, we're holding our breath while we're driving, right? Things like that, that now it goes too far. And so really it's about, can we get you back to normal? And I hate to use the word normal, because what is that? But some like healthy functioning, right? So what is healthy functioning for you? So even when you think about the scrupulosity subtype of OCD, some individuals might pray for 3 hours a day and that's their norm, that's their goal. And some people might want to be able to pray for 5 minutes a day because that's their norm and that's their goal. And, OCD might impact both in different arenas. it doesn't mean that like we have to say, here's the standard, everybody has to get to this one number, right? It's different for all of you. And so what I want us to say about safety issues is that OCD, ERP, we should never be asking you to do ERP that's dangerous, that's high risk, or that puts you in any sort of risk of something happening. But what we should be doing is exposures that I'm willing to do, you're willing to do, that OCD might make you believe is risky or dangerous, right? So when you think about COVID, we never have asked people during the COVID world to not wash their hands if it was recommended, or to not wear a mask if it was encouraged, right? That would be fine. The difference is can you wear one mask? Can you do a 20 to 30-second hand wash and not get stuck doing more, doing 2 minutes, doing 5 minutes, right? And so am I going to ask somebody to touch raw chicken and not wash their hands? Of course not. But do I want you to be able to touch raw chicken, do a normal 20-second hand wash and move on and still cook, versus having to stop what you're doing, decontaminate the whole kitchen, bleach everything off? Yes, of course, because one is OCD and one isn't, right? So sometimes OCD can, if it's real, we're like, oh no, this isn't OCD, this must be real. Remember, if there's urgency and we're taking it to degrees that go far beyond the norm, right? And if they're distressing to us, if they bother us, these rituals or behaviors, it's probably OCD and we want to address it.
Really, really well said. The next one I think is a good question for you, Liz. At 1220 Skylab, Bettina asks, how do you truly separate yourself from OCD? So I wonder if, like you, I mean, I think for so long I thought I was OCD and the urges I had were who I was. So how did you get to a point where you finally felt like you grew into like Liz, the woman, versus like a product of the OCD?
Yeah, it's a great question, because it's hard, right? Especially when we live with OCD for a long time, it does start to become part of our identity. It's not part of our identity we want, but it kind of is a part of how we understand ourselves and how we see ourselves. And so my biggest thing is, I always want to know, if you didn't have OCD, what are things you'd want to be doing? And can we start doing those things? Can we slowly start building that new life and those things that we didn't think we'd be able to do freely? And as you do them, you will be able to start to separate yourself on your own. Ethan Smith and Chris and others, a lot of us have talked about this at the conference. And we also talk about this during the community conversation webinar that happens every Tuesday night at 7 p.m. Eastern time, is for us to really talk about life after OCD and redefining who we are, but also recognizing some of the loss and grief that we have to process when OCD impacted such a big part of our life. And so I think it's normal to be asking that. And I would encourage you to just start learning who you are, and to not expect you to have the answers overnight, but for it to be a process that we come into who we are. Even people without OCD spend their life trying to understand themselves and who they are.
Well said. At 1223, John Dune on YouTube asks, is anger a symptom of any mental illness? I get very angry when I'm overwhelmed. And I want to answer this because anger was a big part of the OCD for me. I mean, I was terrible in high school, and I always look back to those times and don't recognize myself. My sister's doing a talk at the in-person conference, which I'm going to like watch like this, because she's going to talk about it most likely. And it deserves to be discussed. It was horrific, the things that I did and the things that I broke. And it's because when you're dealing with untreated and undiagnosed mental health disorders, you are dealing with stigma, you're dealing with nobody understanding, and you're just suffering, and you just don't know how to feel better. And so anger is a natural emotion that we get when we feel wronged or we feel backed into a corner. And that's how I felt all the time. What I will say is that what I saw in myself, but I also see this in clients, is once they get the diagnosis, they get the proper medication if needed, and they get the proper treatment, most people, the anger starts to fade because they now have a way to fight back against it. So I will just want to normalize that for you, John. And I will say that for me, what really, really happened a lot of times is just the treatment. I mean, that really, really helped me a lot. So I hope that the treatment helps you. The next question is Juan, and it's at 1239, says, I look at things compulsively just to make sure it's all right. So I start to avoid looking at these things. Could this be treated with ERP?
Totally. I don't see why not, right? So again, it's really about the function, right? The function is like, I'm looking at it to make sure things are okay. And so I either am compulsively looking, or I'm avoiding looking at it altogether because it's distressing. And so I totally think it could, yes.
Michael Williams asked at 12:31. It's a pretty long question. You don't have to put the whole thing up, Skyla, but the reason I wanted to answer it is next month on June 22nd, Liz and I are going to be paired with Patrick McGrath, Dr. Patrick, and we're going to be doing a whole talk, a whole lunch and learn on false memory OCD. And this is what it sounds like you're struggling with, Michael, where, you get this kind of thought or image that an incident happened that didn't really happen. And it didn't happen, but then you're ruminating and trying to figure it out. So we'll definitely deep dive into that more. But just to give you a little bit of answers, is that's really what false memory OCD is. It's where an incident didn't really happen. And sometimes clients like you even know it didn't happen, but then you find that frustration and wanting that certainty. And so in that point, you may not be doing a physical compulsion. You may not be driving back around the block. You may not be doing anything like that, but you may absolutely be doing compulsions in the sense of like spending time in your head, trying to figure it out, trying to get clarity, etc. And so what you want to recognize right there is that is the compulsion. And so people will say, well, how do I stop it? What you want to recognize is, what are you trying to answer? You're trying to get clarity. John Grayson and Liz did a great talk on, living in uncertainty. And that's what the treatment's going to ask you, because there are plenty of things throughout your day you don't have answers to, and you still manage to get through your day. So it's really just saying like, oh, in the question you talked about something happening when driving by an ambulance. I guess I don't have clarity on that. And I guess I'll not know about it. And I'm going to choose to move forward. And that urge and that like yelling, like figure it out, I'm going to choose not to give in, just like somebody has to choose not to wash their hands.
That's right.
1246, Mary asks, how does ERP work with real event OCD? Which June 22nd, please come back, Mary. But we can still answer this question. With real event OCD, when one is filled with guilt, shame, and self-loathing of things they actually did.
Yeah, I think it works, it works the same as long as we're actively incorporating self-compassion, right? So there's an amazing workbook by Kim Quinlan on self-compassion and OCD. And I think that that's really important, right? Is if OCD is now attacking this real event, we do want to address it with ERP so that it can be helpful. However, we want to be really cautious that we aren't increasing shame or guilt or things like that, because actually like doing some of the shame, guilt, self-compassion work, that actually can be treatment as well, because a lot of times this, like the way we talk to ourselves negatively or the self-defeating words, can be a part of the OCD cycle or a part of kind of the protective factors.
Yeah, absolutely. And what I would want to add to that too is just like with false memory, is like in real event OCD, what we do is usually it's not an incident that happened like yesterday. Usually it's a past incident from a long time ago. And what people think is like the more that they try to figure it out, the more they try to get clarity, et cetera, the more that they're going to, like the more that we check, the more clarity you're going to get. And that's what Liz was saying earlier, is like compulsions equal confusion. So the more that we try to get clarity and the more that we try to get answers, what ends up happening is it's actually like making a photocopy of a photocopy of a photocopy. We become less clear. And then what ends up happening is now we can't even remember the incident. And OCD is more than happy to fill in the gaps and starts to say like, oh, I think you did this thing and you did that thing. And then you're questioning it, which is making you less sure. And so that's the trap. And so, I think a lot of times people get stuck on the fact that something might be a mental compulsion. What do I do with a mental compulsion? It's so different. What we're really asking you in mental compulsions is most of the time it's to like check, to get clarity, to solve, to fix. And we're asking you not to do that and to sit with that feeling of something being incomplete or not fixed or not solved. And you may feel irresponsible for doing so, but that is where we get better.
Totally.
I totally forgot to ask this question because it was one of the first. It was at 12:03 from Chichanya. Can I ask doubts about therapy? So I know your story, so maybe in the beginning it wasn't a good question because I think you kind of, your parents talked about kind of being forced into it. But once you started getting to a point, how did you deal with doubts with therapy? Like, how did you get to a point where maybe you pushed through the doubts and you felt a lot more confidence about them?
Yeah, I always tell people that doubt and skepticism is good and I want you to have it. Like, I don't want you to show up to my office being like, you're going to fix me and I know this and this is easy, right? Because the reality is that you should be a little bit anxious, like that you're meeting this provider who's going to ask you to do things you've been avoiding, who's going to ask you to do things you maybe aren't sure how to do or what that would look like. And so the reality is that doubt in therapy is okay. It's normal. It's good. And so as long as you're talking to your provider about it, you guys can work together collaboratively to really get some good education. What I don't want is for you to have a lot of doubt and a lot of confusion about why they're asking you to do the things you're doing, but you're not talking to them about it and you're just doing it anyways. We want you to talk about the doubt. We want you to be able to understand the process, the reasoning, and why behind the work that we're asking you to do.
Yeah,
I know we're going to have to stop. So maybe one or two more, Chris, and then Skyla, if you don't mind adding them to the questions. And Chris and I will definitely work really hard to record something where we can go through all these as well soon.
Yeah, I think this is a good one because a lot of people struggle with it. It's at 1250 from Bettina. It's like, how do you stop that? Just one last compulsion, and then I'll do ERP loop, because I'll let you answer it first, and then I'll throw in my 2 cents. But I think that that's something I hear a lot. Or people will say, I have a test coming up, so I can start ERP after. Or like, my wedding is this month, so I'll start ERP next month.
Yeah, I was talking about this with a patient yesterday. One is too many and a million is never enough, and we know that. And often once we start and we give in, we're like, oh, why do we give in? I feel worse now than I did before, or I wish I wouldn't have given in at all. But we all fall into this loop. I myself fell into this a couple of years ago, right before I was having my daughter. I remember I was in this place where I started to feel really anxious of like, okay, I just need to like address all my current OCD or anxiety or triggers, because when I have her, I want it to be perfect. And like, I want to be able to be present, and I don't want there to be anything pulling me away. And guess what? The more I started to give in a little, the more OCD became bigger and all these other things became triggers. And I had to sit back and say, okay, like, I know that's not how this works. And so what I'm going to push you is that one last compulsion has never worked for someone. And it doesn't work for any of us, because one is never enough. And compulsions don't give us clarity. Compulsions get us more confused. And so the more we try to just like, oh, I'm just going to do this one and then I'll address it later. Or if you can just give me this one answer, mom, like this one reassurance, like then I'll let it go. It's not just about the fact that like, there are even some times where that one will make us feel better, but it's the bigger picture. What is that one doing? It's confirming that we need to be scared and that we have to respond to fear. And it's the bigger picture of what does every ritual, every compulsion do to the OCD cycle, which what it does is it makes it bigger, it makes it stronger, it makes it more powerful. And we're really trying to break that.
Kyle asked at 1256, Skyla, I put a link in the private chat if you could put that up. So in regards to relationship OCD, when you start to accept the things one would perceive as flaws, you actually start to enjoy the relationship. And the reason I put the link is we actually had the authors of the link. They were the ones that basically coined the term ROCD, Guy Duran and Danny Derby. They wrote an article for the IOCDF, and they talk about not only relationship OCD, as most people know it, like questioning a relationship, but they also talk another type of relationship OCD where you can become really fixated on a flaw on a partner. And it's never, like you said in the chat, like a red flag flaw, like, oh, they also date other people. But, it can be a certain physical thing, or they might stutter a little bit too much, and the OCD gets fixated on it. And it's not a flaw that you even care about. And that's where the frustration comes. So I really strongly urge you to read that article. But just to kind of briefly touch on it, is the OCD wants you to fixate on that and be so kind of like questioning it and turned off by it that you finally just dump the relationship. And it's like, I can't get over the fact that they have this like ugly tattoo, or I can't get over this fact that they stutter a lot, or, I don't like this thing about them. And once again, it's ego dystonic, meaning it's not something like, oh, I wouldn't want to date a smoker, or, I don't want to date someone long distance. You genuinely love and want to be in a relationship, but the OCD fixes out on something you don't care about. And that frustration is what drives you kind of mad, and you get more focused on that you stop enjoying the relationship. So ERP will work on this as well. It's accepting that this person has this thing that OCD has determined a flaw, and you're choosing to jump in the relationship anyways, even if that means the relationship isn't going to be perfect and it's going to be good enough. So definitely read that article because it answers your question in much more detail.
Absolutely. So it is noon. We have to wrap up. Chris and I are committed to answering these questions. So we will both find time to try to go through a lot of them and get caught up. And our goal is that eventually we can just answer live ones and not have so many backlogged, but the backlogging is also evidence of how much you guys appreciate this and have a lot of questions, and how much we can continue to hopefully support. So thank you, Chris. I always love sharing the screen with you and being together, and it is just a pleasure for us to get to work with this community and to get to hear from each other and connect with one another. I love, I know it's hard, and I want to recognize that many of you are in really tough places and you're asking really hard questions, but I love your willingness to show up, to be present, and to be here, because that is evidence of how much you want to get better and you want to address OCD. And Chris and I are here for that all day long, all of our life. So thank y'all for joining. As always, please remember, help and hope are always available. Chris, final words.
Yeah, I was going to say, Ashley Rivera, Michael Williams, we got your questions down. Please come back. We will be back next week. Is our lunch and learn on orthorexia.
Yes.
So make sure you're here next Wednesday, which that is the 25th, I believe.
And we probably will spend that answering any eating disorder questions, ARFID, orthorexia, kind of like anything among disordered eating and OCD and the connection between the two.
Yeah, so we're with Kim Quinlan next week. Please come back. We'd love to see you next Wednesday. The following one on June 1st, we'll definitely have a psychiatrist, and there we will answer all your medication-based questions. And then Michael and Ashley, we took your questions down, so we'll get to them as well. Like Liz said, thank you so much, everyone, for always coming out. We are so excited to do this. We're always pumped, and we love being part of this community. So thank you. And I'm going to throw it out there one more time. Please make sure you come out to the conference. I'm so hyped. The more we talk about it, I'm the more excited. So it's July 8th through the 10th. There's some activities on the 7th in Denver, Colorado. Make sure to go to iocdf.org/conferences, and you'll find out all the information about all the conferences, including the live one. And we would love to see you there.
See you guys.
Bye. Thanks, everybody.